The Right on Point podcast is a candid discussion of your legal rights, civil liberty ramifications, legalities of possible mandates of COVID vaccines, and actions by our federal government and state governments. Plus exploring the untouchable topics within the National Vaccine Injury Compensation Program, the PrEP Act, and the Countermeasures Injury Compensation Program. Welcome to the Right on Point podcast with Wayne Rohde.
Thank you for being here today on the Right on Point podcast. I'm your host, Wayne Rohde. Thank you very much for following along. Many of you know that one of my favorite guests on this show is a fellow Minnesotan who I've gotten to know very well, Kim Witzak. And she recommended our today's guest to me and said, you need to get him on this program and talk about his work because it's more relevant now than when he originally wrote his books. And so what I've done is I've cordially invited Alan Cassels to come onto the program and talk about his first book, or one of his books, Selling Sickness: How the World's Biggest Pharmaceutical Companies Are Turning Us All into Patients or Customers. For many, the last 4 years have been a big awakening regarding pharma corruption and our federal agencies here in the United States, HHS, CDC, NIH, FDA, and all the other little three-letter acronyms that are out there. Some of us have been involved with this for over 20 some years, me personally with my son. But it's rather interesting. This is what we see here with today's guest and his work. And Alan Cassels wrote a book, co-authored a book, along with Ray Monahan, called Selling Sickness, nearly 20 years ago. And people need to come out there, and there you see it up on the screen, the book graphic. It's only got 10 chapters, but the chapters are loaded, and they're more, to me, with all due respect to the author, they're more relevant today. And we're going to talk a little bit about it, but I want to welcome to the show Alan Cassels. Thank you very much for being here today.
And thank you for inviting me. It's my pleasure.
Well, I'm kind of honored and I'm kind of excited now that we're going to talk about this, because this book, and I know you've got several others that we're going to kind of briefly talk about too, but this one caught my attention. And one, Kim Witzak, good friend of both of us, told me, you got to read this book and then get him on the program. When I opened up the book, and I read books differently than most people, I open up the book and I read the table of contents. Then I read the first chapter. Then I go to the last chapter. Then I come back to the table of contents and start hunting. It's the way I've done books all the way since 7th grade. My English literature teacher back then said, you can't read a book front cover to back cover. And I said, nope, not even the Bible. Just the way I am. And it's just the way it is. But so I read the prologue, and then I hopped to the last chapter, and I said, oh boy, now I got to get into this thing. And if you don't mind, why did you write this book to begin with? I mean, I can understand the contents, but why was it you that decided to do this?
So I had been studying when I wrote this book, doing the research on it in 2004. So I'd been a drug policy researcher for 10 years at that point, and we really kind of immersed in the marketing of pharmaceuticals. But it wasn't just the marketing that sort of caught my attention. It was the way that diseases were being, in a sense, colonized, created and shaped by the pharmaceutical manufacturers. And we saw this through a whole bunch of different conditions. I mean, the book has 10 chapters and we discussed 10 different conditions, but some of the things are I think would be most eye-popping for people is that something as simple as the level of their cholesterol and the machinations that went behind essentially the creation of this disease called high cholesterol and how the pharmaceutical manufacturers, it was extremely large amounts of money involved in chemically altering people's cholesterol. And to what benefit? And most people who are told they have high cholesterol will, listen to their doctor's advice and say, "I should do whatever I can to bring that down," without realizing that what was considered high is a level that has been shaped and altered by the very companies and the specialists they employ lower. And so, we found some astonishing things in the US. They changed the level at which cholesterol would be considered high overnight. And that increased the population of people who would be prescribed cholesterol-lowering drugs by something like 50 million Americans. Nothing changed in the drugs, nothing changed in the evidence or the rate of clinical trials that were being used. It was just the manufacturers saying, let's get our people on the guideline committees, let's reset what is considered high cholesterol, and hence we are massively expanding our market. And I don't want to point out specific pharmaceutical companies, but many of them were involved in this. Pfizer being the leader at that point. They had the blockbuster drug called Lipitor or atorvastatin, which was about the third or fourth cholesterol-lowering drug that came around, and massively marketed, invested in patient education, in the education of cardiologists and physicians, and really redefined what disease is. So I would argue probably of the 10 conditions, the cholesterol is probably the most interesting because it affects everyone. And this, in our opinion, was a clear example of disease mongering. And the reason, Ray had been a journalist for the British Medical Journal, had written a lot about disease mongering, as had I. And we connected together at a conference in Ottawa, and he asked me if I would co-write the book with him. And it was an absolute pleasure. What's interesting about it is that you have an Australian journalist and a Canadian researcher together, mostly writing about the US pharmaceutical industry. So, of course, it affects everyone. In many ways, the US is a leader when it comes to redefining diseases and then marketing the pills to treat them.
Well, the US is probably the world's largest pharmaceutical market, and so therefore,
Absolutely.
and
Something
most
like
profitable.
5% of the world's population lives in the US, yet 70% upwards of the prescription drugs market in the world is an American market.
Well, you mentioned cholesterol, and therefore most doctors are going to put their patients on statins, and then we know what the problems are coming from there. But would you agree that another medical condition that probably the same path would be high blood pressure? Because
Absolutely. In fact, there's a chapter in the book on high blood pressure. And again, high blood pressure is something that has been reshaped and redefined over the years. It used to be, say, 25, 30 years ago, if your blood pressure was 150 over 90, physician might say, oh, it's a little high, maybe alter your diet, get some more exercise, not worry about it. Today, if they're not medicating you to get your blood pressure down to 120 over 80, which is quite a jump for a lot of people, a lot of healthy people, otherwise healthy people, then the doctor might be accused of committing malpractice. What has changed over the years has been just this drive to medicalize and medicate our blood pressure, our cholesterol, the density of our bones, etc. Yeah.
um, couple months ago, I had as a guest Dr. David Healy on, and we were talking about SSRIs, the antidepressants, and then now the current target is one of them is pregnant women. And you've got a chapter on depressants here. This to me it's very dangerous, but with your knowledge and expertise, what is actually happening over the last 15, 20 years regarding antidepressants? And now we're going after children, which I think is disastrous, and pregnant women.
Absolutely. So I mean, the whole basket of psychiatric drugs. So antidepressants, drugs for ADHD, drugs for bipolar or psychosis. Again, those markets have increased dramatically. Probably the biggest and probably most worrisome current example isn't the use of antidepressants, it's the use of ADHD drugs. where it used to be those drugs were largely targeted to children, mostly boys who are disruptive and perhaps can't sit still in class. And you get the whole medical establishment involved in educating teachers about what is, what is considered to be a diagnosable condition. It's highly controversial. Again, the ADHD market is mostly a US market. You don't see that rate of prescribing of ADHD drugs anywhere in the world like you see in the US and increasingly in Canada. And over the last 4 years, so since the pandemic, the prescribing of ADHD drugs has risen by something like 50%. And these aren't just children, so they are targeting adults. And so, okay, you've got a variety of ways in which social media influencers, the pharmaceutical companies, and specialty clinics that are seeing people who have, say, difficulty paying attention. Maybe they lose their keys. Maybe they have trouble finishing their sentences because they're so excited. You have things like these self-administered questionnaires. So they'll give you a list of 10 questions and they'll say, do you sometimes trouble losing your train of thought? Or do you sometimes not finish projects that you start? Do you sometimes lose your keys? Things like this, which most normal people out of those 10 questions are going to answer 6, 7, 8 of them in the affirmative. If that's the case, then you may have ADHD. See your doctor. And of course, the punchline of seeing your doctor is the red flag that goes off, because what can the doctor do that no one else can do? And that's prescribe you, and in this case, a stimulant, an amphetamine type stimulant that may or may not help you. The question is this a disease that we're treating, or is this a socially constructed condition? And I would argue, and I think we argue in the book as well, that at the extreme end, again, let me be clear, at the extreme end, some children and maybe some adults might be helped by being treated with a stimulant, okay? That's not the biggest market, though. The biggest market is people who are questioning their ability to cope, who are being told that you might have a diagnosable condition, and hence those people are being drawn into the net of a diagnosis and a drug. And you might say, well, what's wrong with that? Well, the whole problem of overdiagnosis, when you've got people who are not, probably not the real candidates, which were even studied in the trials, are given these drugs, and those drugs, if they have no benefit, they will almost always have some level of harm. I know we could go into that, but the main thing that if you've got people who are distracted, say you've got one of these, a phone which goes off with notifications every once in a while, you find yourself distracted. Is that a medical condition? And I would argue that no, it's a social condition, and you should treat social conditions with social remedies. You don't throw medicine at what is considered to be a social condition. And we're all distracted. I mean, we are more distracted now than we were possibly when these drugs were initially launched. Clear, that's true, except we have created a society in which distraction is a kind of normal part, and it's sometimes very difficult to get tasks and jobs done because we're distracted. Will you be helped by medication? Well, possibly reducing the distractions and allowing yourself to focus a bit better as opposed to taking a drug might be the best way to start.
Well, one of the things that's popping up in the last couple of years, we've come out of this COVID pandemic and we had this lockdown that was ridiculous, and people are starting to analyze the harms that it did, especially to children not going to school, the lack of social interactions, and so you're seeing issues dealing with young kids. But we're now looking at what is happening, what they call, I guess, school-based health centers in schools, and they're pushing mental health. And what I'm noticing here is that they're trying to drive a wedge between the parents and the doctors, and allowing the schools, through school nurses and psychologists, whatever, to meet with these kids and push them and trying to figure out, I think you're starting to see a big push in prescriptions, or the need to have artificial mental health instead of just actually allowing your body to learn how to cope with things. They want to use an artificial drug or whatever medicine. So I'm
Yes.
really concerned with that.
I think you're absolutely right. The mental health enterprise, so to speak, that has inserted itself into our schools is
Right.
highly problematic. It leads to amateurs, being say teachers or principals or school counselors, recommending to parents that their kid is behaviorally disordered of some sort, and recommending drugs. So that's a paradigm that we used to have. The school was most interested in the health and welfare of the patient of the students, but now it seems like they're very interested in the health and welfare of the medical the mental health enterprise. And I think it's gotten a lot worse. Certainly with ADHD, certainly with just a range of things that they're doing in schools that in many senses are causing some level of mental distress. I mean, for example, I don't know what it's like in your jurisdiction, but here there's a big major argument about whether we should be allowing kids cell phones in schools.
Mhm.
And the teachers that I know are telling me it's an absolute disaster. They can't get anything done. Nobody pays attention. They're constantly looking at their phones and texting their friends and checking whatever Facebook or Instagram or whatever. Uh, that's not a good learning environment. I mean, most right-headed parents are going to say, forget it. You're not going to school with a cell phone because you're not going to be sitting there paying attention and learning. And but you can imagine it's not just big pharma that's pushing back on on parents asserting these kind of things. There's big tech as well. Imagine if they brought out a national ban of cell phones in schools, how the big telephone manufacturers, the cell phone companies, and so on would be up in arms because they're going to lose a major part of their market. You know, independent experts that have looked at this have said that allowing phones in schools is a non-starter. You should completely get rid of that, and I would totally agree, because a kid is distracted and so on from their phone. That should not be leading to a mental health diagnosis and a medication.
Well, here in Minnesota, there is a lot of pushback on cell phones for kids in schools. But what several school districts are starting to do, or a few school districts, teachers are actually having each of the students check their phones in when they go to class, putting them in a container so they don't have access to them during that period of study. Yes, they'll have it in the hallways and whatever, but it's at least something. And they've noticed more attentive students. They've noticed a few other things. Students are willing to, for most part, willing to put their phone in a box, and as long as it's because they might have an important message come through from their parents or someone else, they can check that during in between periods or when they're out of school. But you're right. Cell phones, I think Dr. Phil said it on his show the other day. He says is that the kids have gone from living their lives to actually watching other people live their lives on a cell phone instead of living their lives.
There's a lot of serious documented harms of not just cell phones, but social media in general on children. Again, a social problem that should not be treated as a medical problem. That would be kind of my bottom line.
I got two other questions about this book I want to get to. One's very relevant to my son. And then I want to get into your other books because I think people need to know them. You have a chapter, Taming the Watchdogs, basically irritable bowel syndrome. And let me lay out what happened. My son had severe gastrointestinal issues when he was young. We found out they had the live measles virus living in his GI tract. We did vitamin A to try to extract a lot of that. We were going to some doctors and we were living in Oklahoma at the time. And they're all saying irritable bowel syndrome. There's nothing really we can do other than we're going to put you on these medications, and he's going to have to take it for the rest of his life and stuff like this. And we got up and walked away. And it wasn't until we found a doctor that actually decided to scope him from his mouth to his hind end and put a pill cam in his stomach to actually see what was going on. It was very a lot of redness and soreness. And from there we decided, he said, you can fix this by a dietary change. So what we did is we went on a gluten-free diet. It's not for everybody, but we went on a gluten-free diet.
Mhm.
And within 4 years, completely healed. I mean, he had ulcer, everything else. He was, as a young kid, he was bending over on chairs because he tried to put pressure on his stomach because it was hurting so bad. Some other things. And when he swing out on the playground, he lay over on the swing and try to swing that way, puts pressure so it wouldn't hurt so bad. But we went on and did that. So I think a lot of people, with this irritable bowel syndrome, I think that it's driven by pharmaceuticals. The doctors are just saying, hey, this is what it is. But I'm not saying everybody should go on gluten-free. I think everybody should try to remove a little bit of gluten from their diet. I think we consume too much gluten. But also the fact is that for him, that's what did it. And he's 26 years of age today. He's strictly gluten-free.
Mhm.
And he does not have those tummy issues.
That's funny. My son just became gluten-free in the last year. He's 27, 24 years old. So yeah, it's and why are so many people developing gluten intolerances? I have no idea. I can't really answer
Don't
that
know.
question. But like as you what you're alluding to is that until you get to the basic problem that's causing the issue, piling medications on top might help, but they also might prevent you from actually getting a proper diagnosis, right? And so I think in your case, you're lucky you were able to get a doctor who kind of did the investigative work that you needed to do.
It was a kind of controversial doctor, Dr. Arthur Kriegsman, but he was able to do the scoping, and we looked at all the video. It was unbelievable, and then we were able to, a few years later, be able to do it again. Boom! There's proofs in the pudding there. I mean, it's a clean GI tract and stomach, no issues. So,
Good.
and it's kind of tough. I'll tell you this, as men, as we get older, colonoscopies, come to be a thing, and we have to do the prep work a couple days prior. To do it in a young kid is kind of difficult to do the same thing. It's tough, but
Yeah.
thank goodness though, he is
Y-
not in pain. It was a lot of work for about a week, but we did it, and so we saw so many doctors, and it's just tough. And we instead of trying to manage, we tried to figure out what was the core problem and see if we could fix the core problem.
Good. Yeah.
So the last point I want to talk to you about in this book, and it's probably the most controversial today, and that is sexual dysfunction or gender dysphoria. That's a difficult topic to talk to people about, because some people are going to be offended, other people, whatever. I'm not going to go into the morality of whether or not we need to have surgeries and things like this and let people transition, but what is causing you're talking about sexual dysfunction? Are we talking more about infertility, or are we talking what is actually happening here? What are you trying to, the message you're trying to portray to the
So
reader?
20 years ago, when we were looking at this, we started noticing conferences, international conferences that were being set up to try to define female sexual dysfunction. Okay, so the way the pharmaceutical industry saw this is that at that point, the drugs for erectile dysfunction, so Viagra and so on, widely marketed. fairly successful for some men. And the question was, how do we deal with the sexual dysfunction in the other half of the population, the female? The problem was they had a lot of difficulty defining what was sexual dysfunction in women. Is it just disinterest in sex, or inability, dryness? I mean, there are a number of things. And let's face it, the natural course of human sexuality, most of us, as we get older, our sex drive drops, and both for women and for men. Sometimes men have a stronger sex drive, therefore it can cause a problem in a relationship, and the woman's sex drive is not matching theirs. And so the industry spent tons of money and tons of research time trying to research what pill they could come up with. And I can tell you, it has been an absolute disaster. They've come up with a number of treatments, and frankly, I can't remember the names of them, but I think the treatments that were come up, and they were marketed on the basis of equality. Like, men have treatments for sexual dysfunction. Why shouldn't women? The problem was that the drug, one of the main drugs that was launched, great fanfare. They recruited women's health advocates and so on to be promoting, was that they were basically reshaping what is a normal sex drive. So for us, normal is it has a wide confidence interval. For some people, once every 2 months is normal. For some people, it might be, I don't know, once a day. So when you start involving the pharmaceutical industry in defining normal, then what you do is you lower the bar for everyone. Therefore, many women would be targeted and marketed to that, if you have disinterest in sex, you might have a sexual dysfunction. Therefore, you might be a candidate for this latest pill or this newest pill. I think the last chapter in our book, we kind of blew that one out of the water. We said, this is such a gross example of disease mongering, of taking the normal ups and downs of female sexuality and shaping it in a way that it becomes an automatic treatment for a drug. And the interesting thing looking back is that condition has never really caught on. They have not been able to convince women or large numbers of women, that they need to be medicating their sexuality. So it was a bit of a failure, but the amount of money and energy they put into that was huge. So that's a little bit something different than gender dysphoria. I mean, 20 years ago, I didn't know anybody who had a daughter or son that were questioning their sexuality to the point that they would go to the doctor, start getting treatments, sometimes hormone treatments or estrogen treatments, testosterone. I can tell you, in my small town here, I know 5 people, 5 friends of mine whose daughters have transitioned to boys. And they did that somewhere between 14 to 16 to 17. This includes changing their name, taking testosterone, other treatments, breast removal. And, and this has happened to friends of mine, and I have huge amounts of sympathy for the difficulty that their child is going through. Though, when you look at the research, the most surprising thing, there's actually a very big study that came out of the Netherlands a little while ago that found that, and they tracked quite a large cohort of kids over the years, asking them about their feelings about their gender identity, and found that something like 80 to 90% of those kids who claim some level of gender confusion, if you want to call it that, at a younger age, grew out of it. So what that tells you is that if you're going to, and maybe some people won't grow out of it, and as they're adults, maybe they would feel more comfortable being the opposite gender. Great. What the controversy comes is that if you're putting someone in the direction of fairly serious medical intervention at a young age, when they haven't even sorted out their whole identity, never mind their sexual identity. My one friend whose daughter transitioned, I asked him, what's going on here? And he's a kind of a historian of music and quite a strong culture critic. And he said, what's happening is this is the new punk rock. And when he said that,
Oh,
it sort of put it into context for me, because when I was a kid in the 80s, punk rock was a way that you rebelled against the establishment, you know? It was your anarchist self trying to establish some identity. And for him to say, this is the new punk rock, that really kind of, I think that kind of nailed it for me. But at least with punk rock, you might get earrings and facial tattoos or whatever, but you're not doing major surgery on yourself as a developing human. As you can imagine, it's very controversial. There
yeah.
are, but I can tell you, Canada and the US are kind of unique in the world in not just promoting, but actually publicly funding gender reassignments and gender transitioning medical services for younger people, like people, we'll say below 18. Whereas in Europe, you know, France and in the UK and in Scandinavia, they basically said, forget it. The harms are unknown. Kids typically will grow out of this. Therefore, it's irrational and possibly unsafe to be promoting gender changes for young people. And I think the European uh, um, model is more rational. It's more. It's actually looking at the long-term trajectory of a lot of kids, which is you have some dysphoria or confusion or identity crisis as a young person, but you grow out of it.
Well, in the autism community, and I'm very well versed in this because my son, now 26,
Yeah.
he's more on the severe end of the spectrum. But I've noticed girls who have a tendency to be diagnosed later than boys with autism spectrum disorder.
Okay.
The high functioning segment of that spectrum used to be called the Asperger's. A little socially awkward, high functioning. They still, go to school, work, whatever, but they have some social quirkiness about them. I see them as the target of this gender transphoria, surgery, and they're targeting that segment. That really is bothersome because these are girls 10, 11, 12, 13, 14 years of age that are trying to find their own identity, trying to, and they're not being accepted by everyone and being kidded. And, kids are cruel to each other if you don't fit a
Yeah.
certain norm. And so I see them being targeted. Now, where it gets really concerning to me is like here in Minnesota, our state legislature in the last couple of years, this and really bothers them. They've passed legislation to kind of create a sanctuary type state. So kids can come in from other parts of the US and start getting treatments, surgeries, and whatever without parental consent. They can come
That's
into the state and start getting these hormone treatments, et cetera, whatever all it is, without that. And then this year, they're passing legislation to have insurance as an insurance mandate to provide insurance coverage.
Mhm.
And it's being driven by a few, like there's like three state legislators that that have transitioned as adults. Okay. And they're driving. And I think there's a lot of other state legislators that are scared because of the militant type following that these people have developed, where they're going to get ridiculed and attacked if they don't go along with this. So I'm really concerned about where this is heading, especially
Yeah.
for the kids. For the adults, you can choose what you want, but it's this, you know, it's the puberty issue that we're interrupting, and it's going to
Mhm.
cause lots of problems. This is the way
Yeah.
I see it. You're messing around with hormones, puberty, all that stuff, and it doesn't have a good ending as far as
Yeah.
that's why I think
Absolutely.
Europeans are right.
I was interviewed by a journalist on this very topic a few weeks ago, who was examining the costs of treatments And my position is fairly simple, and that is any drug that is prescribed for a person that doesn't need it, that's a wasted dollar. Any dollar spent on a drug that's not needed is a waste. And so you have to really examine what need is. And again, I think the Europeans have at least set the bar for people, young people, making those decisions when they are more mature. And uh, but there's also a lot of, like there is with the pharmaceutical industry, there's lots of vested interests who are making a lot of money on providing these kinds of services and believe that these children should be offered these services. Just like the companies that make a lot of money selling cell phones to children, when we know cell phones and social media are an overall harm to a lot of kids. And so I mean, as parents, as consumers, we have to push back. And what Kim and I would argue is that we have to start unselling sickness. So I mean, and this involves, I think, expanding the conversation beyond just say medical experts or teachers, and expanding it beyond that to have average consumers weigh into this, and also to look internationally and say how does what we're proposing, how does that compare to other countries, and if there's a difference, why are they doing things so differently over there than here? You could pick a range of topics like I mean, ADHD might be a good example where the promoters of it here in Canada and in the US would say, it's absolutely important that for kids' long-term ability to achieve academically, to succeed in school and college, these drugs need to be provided. Maybe they should be even over the counter. Well, uh, legislators and medical experts in France would say that's completely bonkers, where they might have 1 or 2% of boys in say middle school or elementary school on some kind of stimulant, whereas some US schools would have 8, 10, 12% of the boys of a certain age to be on these drugs. And it's insane. Can I just say one more thing about ADHD, because the topic
away.
fascinates me. We did a study. When I say we, I worked at the University of British Columbia, and colleagues of mine did a database analysis looking at who was actually being prescribed drugs for ADHD, and they found something very surprising, and they called it the birth month effect. So they compared. I say boys. It was boys and girls, but something like 80-90% of the prescribing of ADHD drugs happens in boys, probably because they just have perhaps more energy. They're less willing to sit down and shut up as they should, and so on. And so we looked at kids born between January and June, took that as a cohort, and took the kids from July to December, and compared those two groups and said, what is the rates of prescribing of ADHD, which is what is the rate of diagnosis? And surprisingly, something like the kids who were born in the latter half of the year, so they're the younger kids, they're the less mature kids, right? I was born in November, so I would have been in that category. They had something like a 25 to 30% higher rate of ADHD drug prescribing than the kids born in the beginning of the year. This birth month effect, by the way, affects the rate at which kids get prescribed drugs for depression, anxiety, ADHD. It has nothing to do with their medical condition. It has to do with that they are taking kids in a classroom, and some of those kids are born in December, and some of those kids are born in January. And guess what? The January kids happen to be about a year more mature than the kids in December. So this was a surprising study, and we found this study was actually replicated in the UK and in the Netherlands, where they have found this birth month effect. It's
Oh,
quite
this is
fascinating.
fascinating. This is
And you
fascinating.
see this, by the way, you will see this in something like in professional sports. So I'm a Canadian, so everyone plays hockey, and they find that the kids who are born between January and say June have a much higher rate of succeeding and going on to become professional hockey players than the kids born in the latter half of the year. Why? Well, because those kids are in the same cohort. They're stronger, they're older, they're more mature, they get more attention from the coaches, and they end up excelling more in the sport. It has nothing to do with their innate ability. They just happen to be in a group where they have an age advantage. And in the world of ADHD, the younger kids have an age disadvantage. We should not be medicating kids because they have an age disadvantage in a classroom. We should have a classroom that's big enough and the teachers that are competent enough to say, yes, some kids are going to be younger and less mature, others are going to be older, but it's not a medical condition. Again, you don't prescribe medication for a social condition. You prescribe it for a medical condition, a genuine medical condition.
Let me ask you a question about this, what you're talking about. The schools in Canada, when you are eligible to go to first grade, here in the United States, if you're born, it's August all the way through the following July is when you go to school for the first grade.
Right.
Okay. So if you're born in May, you're in second grade.
Mhm.
You see how I'm cutting up that cohort?
Yeah. So
you are younger. You are younger if you're in the first grade. Well, hold it. Yeah, I guess I don't know. I'm just trying to understand why you would be in the latter part of the year. I don't know how Canada does their school.
So some parents, I believe, they can hold their kids back a year. So for me, we went to school when we were 5. If you turn 5 that year, that's the year you went to school. But what if you turn 5 at the end of December? Some kids turn 5 in January. You're almost a year younger than the. I think, and I have to check whether the regulations change, whether you can hold your kid back for a year. That might be to some advantage. Some people might just say, no, kids got to get out and get involved in the real world. Yeah.
My other son, and my kids are twins. One who's severely injured, has autism, Nick, and his twin brother, Austin. Austin, we did hold back 1 year and made a world of difference.
Yeah.
He went to kindergarten twice, basically.
Oh, yeah.
Okay. And it made a world of difference because once he got into first grade, second grade, he took off studies, working, and communicating, socializing. He was, a little too, they were born in October of 97, but we held Austin back and we went to kindergarten twice. And it was the best thing for him socially and, whatever. So that's interesting what you're talking about. That is, did you examine the United States data at all, or is it just Canadian?
We just looked at the province of British Columbia where I live, though, and this is probably 6-8 years ago. I'm sure that research has been replicated in the US because it has been in Europe in a number of places. Yeah.
Wow. Okay. By age cohort. I'm writing this down because I think this is fascinating. It's really interesting stuff. Okay. Yeah. My guest today is Alan Cassels. We've been talking about his book, Selling Sickness. My understanding, you've got a new one, that you've kind of an extension of the book.
So
and what is it called?
This book is 20 years old, but part of the reason why I wrote my next book, which is entitled Seeking Sickness, Medical Screening and the Misguided Hunt for Disease, because a lot of the people who end up becoming diagnosed, become patients, are there because they have been through some level of a screening test, whether it's a test for prostate cancer, breast cancer, colon cancer, mental health difficulties, depression, and so on. They will have arrived at a point where they are offered or they're pushed into a screening test, and there are many problems with medical screening. And I would argue, a friend of mine said that maybe your book should have been entitled Less Screen Time. And most people aren't going to know this because screening is so much seen as a way to save your life. If you don't get a prostate cancer exam or undergo mammography, then you're going to die from some kind of cancer that's entirely preventable. The problem, though, is that in the screening paradigm often catches people that have either pseudo illness or have a pre-illness that will never go on to hurt them, and therefore any treatment that you do will ultimately cause harm. I mean, one example, you mentioned colonoscopy. There are a number of ways to test if you've got sort of precancerous things happening in your colon. They can do a FIT test, a fecal test, colonoscopy, etc. When they study these, when they study colonoscopy, you would say, wow, if you take 1,000 people and or 2,000 people, you get 1,000 of them, you give them annual colon cancer screening, a colonoscopy for the next 5 years, and you don't do the same with the equivalent cohort, you would imagine, well, those people who have screened every year, they must have wickedly lower numbers of colon cancer deaths. Well, that's not the truth at all. In fact, there's almost indistinguishable in terms of the number of people who die of colon cancer between these screened and unscreened groups. What you will find is that those who are screened are sometimes going to be harmed by the screening itself. As you know, people can experience perforations to their bowel because of the colonoscopy and so on. And so it's not a completely benign thing. It's the same with PSA testing, where they can measure an antigen in your blood and say, oh, well, you've got a high likelihood of having prostate cancer. Well, I can tell you most men will do much better if they do not get tested for prostate cancer and that they live their lives normally, because if you get tested and they find some level of an antigen in your blood, that will lead to things like drugs, chemotherapy, sometimes surgery, and the side effects, the adverse effects are quite profoundly life affecting, including you can become impotent or incontinent just because of the treatment that you've given for something that would never have gone on to kill you. As I said in this book, most men die with prostate cancer, but not because of it, which means that when they do autopsies on men who die in car accidents or industrial accidents or so on, they do autopsies and they find that, oh yeah, they had prostate cancer that they never knew about. It never went on to kill them, even with older men. Now, that's not to say this disease is completely benign. I'm not saying that. I'm saying when you push the screening on younger and younger men, you are going to harm a good number of them. I know a lot of physicians who have told me they would never let anyone touch their prostate, because they will find, if you look hard enough, you will find something worrisome, and it will lead to medical treatments. The same with breast cancer, and at the risk of offending some of your listeners, breast cancer has a very, very low yield. You have to screen thousands of women for years in order to save one life. But when you've done that, those thousands of women, a lot of them will have undergone unnecessary surgeries, drug treatments, chemotherapies, and so on. And so this is why I wrote the book Seeking Sickness, is because most people would say, well, better safe than sorry, right? Better get the tests, because you don't want to regret it. I argue in the book, look before you leap, which is you're getting a test that is going to expose you to a potential harm. You have to examine that. You have to do your own research, and you have to realize that there is a huge vested interest in an industry that is set up to promote screening on healthy people. Again, I'm talking about healthy people, no symptoms. You're offered a screening test, and so I mean that's in the world of cancer, but in the world of, say, mental health, the screening test, most people are not going to, the screening test for depression, I think it's called the PHQ-9. It's copyright by Pfizer. So why would one of the world's largest pharmaceutical companies have a screening tool to look for depression? Well, because that's a tool in which they can expand the market for their antidepressant. And clearly, what kind of world is this? And we allow the pharmaceutical companies to design the screening tool which throws a net out and draws patients in to become lifelong customers of their drugs. Sorry, we do this with mental health, with depression, with ADHD screening, and so again, if you're worried about anything related to a preventable condition that you think you need to be screened for, you should read my book, and maybe you will get a second opinion. Um,
Personally, I had two uncles that died from colon cancer, one on each side of my family, my mom's brother, and on my father's side. So, of course, I go in on my 50th. I go into colonoscopy, and doctor says afterwards, says, "See you in 10 years." I did it again at 60 years of age. See you in 10. Okay, I don't think I'm going to be running these issues anymore, but I just did it that way. So I can understand, some people that might have had a family history of a certain type of
again,
issue. Well, you do have to take precautions. But
again,
as you
yes,
said, though, majority of
you
people, just
might be in a
healthy people,
different.
don't mess with it.
Yeah, you might be in a different category. I mean, if you
Yeah.
had both parents who died from a certain type of cancer, that slightly increase your risk of you getting that cancer. So maybe you're in the category where more frequent screening and investigation makes sense. Absolutely.
I haven't read this book here. I'm going to get it right away because this is astounding information. Do you address a few years ago, maybe, I don't know, 6-7 years ago, it was kind of all the rage of a lot of women who would get genetic testing to see if they had some type of a gene marker for breast cancer, and then they would go in and have surgery to remove their breasts. I don't see too many. Well, I think I haven't heard too many in the news about celebrities doing this anymore. Maybe there has been, but
Yeah.
what's that all about?
So you're talking basically genetic testing for a lot of things, and I would argue that like any test, you have to say, what are you looking for, and how would you act differently depending if the test was positive or negative. And in some cases, if say your genes, if you can't do anything about it, it's probably not worth knowing. I mean, I I would argue that the why you want to be cautious on any kind of screening is that it's going to have a psychological impact on you. If I screen you and say, "Oh, you've got high cholesterol," suddenly you went from being a person who's just normally living their life as a happy-go-lucky podcast guy. Next thing you know, you're living under a dark cloud because you're being told, even though your risk of developing any level of heart disease, if you've got somewhat elevated cholesterol, is minuscule. People live under dark. It's sort of like I hate to say, but let's bring COVID in there. People brought the fear of catching COVID without understanding the statistical likelihood of it happening. So you say, well, what do you mean by that, Alan? Well, you saw, bodies being loaded onto gurneys in northern Italy or in New York City, and you have this fear. The question you have to ask is, what is the likelihood of a person your age dying from this disease? And when I looked at that in the early days of COVID, when you had independent researchers looking at the IFR, which is the infection fatality rate, which is how many people get infected and then will die from this condition. For someone my age, say a 60 plus person, which is a little higher risk than young kids, the risk for young kids was very small. For people my age, it was something like 1 in 10,000. Risk of a disease is 1 in 10,000. How much can you do to reduce that risk? Do you want to reduce it to 1 in 20,000? Well, you could drop. So, but statistically, your likelihood is let's say 10,000. It's 9,999 chances out of 10,000 that you'll be fine. So we have to understand what our risk is to start with to really understand what the benefit of any treatment is. And again, I would argue with whether it's high cholesterol, COVID, high blood pressure, most people, and including physicians, I know because we've done surveys of this and we've done focus groups, most physicians will exaggerate the risk of the
Really well.
marker. They will exaggerate, and therefore they will also exaggerate the potential benefit of the treatment. And if you don't have a realistic idea of what the overall risk is, then you're never going to make rational decisions about whether to take a drug or not. So I would, whenever anyone is offering you a screening test or a drug, the question you have to ask is, what if I do nothing? What if I do nothing? And a good physician who understands the epidemiology and the statistics might say, well, if I don't give you this COVID vaccine, you have a 9,999 chance out of 10,000 of never dying from COVID. Okay, well, those are statistics I can work with. And then you make a decision whether you want to take that 1 in 10,000 chance of having a benefit from the vaccine. So, selling sickness was about, there's a lot of money to be made in exaggerating disease, including lots of fear mongering and disease mongering around what could happen to you. But unless you understand the statistical likelihood of something happening to you, you're not going to be able to make good decisions. So again, most conditions, and again, I'm talking in healthy people, not people who are going to the doctor because they've got symptoms. I'm talking about healthy people who are out of the blue told you've got low bone density, high blood pressure. I was told I got high eyeball pressure. Okay, so what does that mean? And you need to understand it in the context of, a lot of times it means nothing except a psychological burden that you now have to carry. You can't untell people that they have a condition, and that is the problem with throwing out diagnoses of, this kid's got Asperger's, or this one is pre-autistic, or this one has pre-diabetes. When you do that, you are burdening people with a disability that may never have any impact on their lives. Therefore, they're carrying that weight. They're living now under a dark cloud and thinking that something's going to strike them down. I think it's malpractice, frankly, to be doing that.
Okay, we only got a few minutes left. You got a couple other books. Briefly, can you point those out? We're going to put them up on the show notes so people can go get them.
This was a fun little book that I wrote after Selling Sickness. So this is the ABCs of disease mongering, and it's written in verse form. So
Okay.
it's like Dr. Seuss, right? So there's a condition and a poem for each one, and so 26 letters of the alphabet. It was quite easy to figure out 26 verses to describe what's happening. And then in the back of the book is what I call the fine print. So I describe, why did I write that poem, and why would I try to deconstruct that?
Okay.
So and it was fun. And this book actually became a bestseller in Canada because it's only it's only 100 pages, and it's kind of fun. And it's illustrated.
Dr. Seuss is a favorite of my son Nick, so I read a lot of Dr. Seuss with him.
Perfect.
And,
yes.
But you got it in a verse, so it makes it fun to read instead of a boring textbook. You got it. Okay.
That's kind of what I think, and I think most people who, and I've gone and done public lectures and talks about this book, and I'll read some of the poems. We'll just discuss them, and most people come back and say, yeah, the poem just pulled me into the topic. I never really thought about, why should I question my osteoporosis diagnosis? Well, you read the letter O for osteoporosis, you'll figure that out. So
terrific.
That's
wonderful.
Yeah. So the last book. So you've heard of the Cochrane collaboration,
right?
So this is a group that highly respected international group of largely volunteers and researchers that assess medical interventions. They try to take all the evidence of a particular medical intervention, the good, the bad, the ugly, assess it, and try to basically create a meta-analysis, or what they call a systematic review. They'll systematically review the evidence and come out with recommendations. Probably, I would argue that some of the highest quality medical evidence we have is coming from systematic reviews, and those systematic reviews done by an independent group like Cochrane will be the highest quality. So the group asked me to write. They had their 20th anniversary about 10 years ago, and they asked me if I would write a book about the social history of the organization, and it was fascinating. So I traveled to Oxford, to London, to Madrid, to Keystone, Colorado, all kinds of places to interview the characters that make up the Cochrane collaboration. And basically, I would argue
Is
that
it a backstory of the Cochrane collaboration?
it's kind of it's kind of how the organization got started, why we needed a group like this, who are the characters, and that's what I really got into. Is the characters that are inhabiting this book are fascinating, driven by science, very allergic to bias, very willing to challenge orthodoxy and challenge the pharmaceutical industry and the medical experts to say one thing. And they say, well, when we assess the evidence in a quality assessment, we find something different. And I would argue that they produce some of the best medical evidence out there. The caveat being that Cochrane has undergone a transformation over the last, let's say, 5 years or so. There's been some controversies within the group. They ejected one of their major founders who started the group because they didn't like his controversial views on things like mammography and psychiatry. Peter Gotche, I don't know if you know that name, but
You know him? Yes, I do.
Peter was one of the founders of the
Mhm.
Cochrane Collaboration, very outspoken Danish physician, researcher, and he was kicked out of the organization. And it of course, it was a very political decision. It didn't have to do with the quality of his work, and the group has become somewhat corporatized over the years. I mean, I can't get into the full depth of the controversy, but let's just say that solid work, and it was really worth writing a book about that. Because when I say it's medicine's best kept secret, this is what I tell people when they say, "Hey, my doctors put me on this drug, or they're thinking about this treatment." I will say, "What does Cochrane say?" They, well, what do you mean? Have you checked the Cochrane library to see if there's a systematic review on that particular drug for a person who has the condition that you have? Because you might get a much better view of things than just listening to, say, somebody who's promoting a
Sure.
certain medicine or viewpoint. Yeah.
Well, where can everybody find your books? In your website, or is it out on Amazon, or where?
Yeah, my books are available on Amazon. I'd be happy to people to contact me. I have copies here I could send. Certainly, the ABCs of disease mongering might be difficult to find, but the last I checked, it was available on Amazon. And yeah, so I should tell you, just I'm sure we're almost at the end of our time here, but Kim Witzak that you mentioned at the beginning, her and I are looking at the 20-year retrospective of Selling Sickness. And we believe that something has to happen, not only to mark this kind of 20-year milestone, but something to start unselling sickness, to wind back this this overdiagnosed, over-medicated, over-medicalized society. And so we're working together to put together a docu-series, kind of a documentary, probably a 6-series documentary, which we're provisionally titling Unselling Sickness. And so stand by for that.
Oh, we'll look forward to it. Yeah, Kim kind of hinted, but she wouldn't tell me everything because she said she wasn't at liberty to disclose. But she
Yeah.
said she was working on a project with you hopefully in the next couple of years to come on out. So
Yeah, yeah, probably this year sometime. So we'll see.
look forward to it. And then when that does come out, we're going to probably bring both of you back on together and we can talk about it. That sounds fascinating.
That
So,
would be great.
well, it's been a truly a privilege listening. It's quite interesting to hear what a historical perspective, because most people only have seen what's happened the last 2 or 3, 4 years.
Mhm.
You know, a lot of us have been in this game for a long time. Myself as a parent, when I've been called a tinfoil wearing parent, crazy parent, I said, this is what we've been talking about, and now finally people are
Yes.
understanding it and more
I
and
think I
more. But
think Wayne, you're in the category of people, and I know a number of them. I've met many of them over the years. You become an accidental advocate.
that's right.
You didn't expect to do what you're doing now, you know, when you mapped out the trajectory of your life. Same with Kim. Something happens and that it galvanizes and life is giving you kind of a purpose and a mission. And it's tragic that you have to do that because of something tragic happening in your life. But what you're giving back to people is so important and so valuable because people need the voices of those who have become advocates for very good and strong and powerful personal reasons.
Well said. Thank you very much. Okay, you've been watching and listening to the Right on Point podcast. It's a candid discussion of your civil liberties, issues, and your legal rights with your government. We discuss what no one else will by digging deep into vaccine injury compensation, into pharmaceutical corruption, and also the corruption of our government public health agencies, the legalities of the COVID pandemic, and what is happening in our global community around the world. I want to thank my guest today, Mr. Alan Cassels, to discussing his work, Selling Sickness, and his other 3 books. Ben Smith with Backwoods Media is my video editor. He's going to have some work to do, but thank you, Ben. Thank you to the many listeners and viewers of this program. I appreciate your generosity and donations to keep this program moving forward. As always, every week I leave you with the following, and that is keep learning, keep challenging yourself, and always, always question authority. Have a good day, everyone.